It's a pleasure. Okay, so I'm gonna try to present 3 quick cases if I have time, or else I'll do only 2 cases. But anyway, this first case, we have a 78-year-old female who presented to our institution with symptomatic mitral stenosis, and she kept on getting admitted with flash pulmonary edema. Her past medical history was significant for HFpEF. She had complete heart block, for which she had a dual chamber pacemaker. She had chronic atrial fibrillation, and because of her recurrent admission with heart failure, she had recurrent pleural effusion that required pleurodesis. This is her echo. She had a mean gradient of 16 with the mitral valve area of 0.7. There was no LVOT gradient and no aortic stenosis. This is her 2D TTE. You can see significant MR, a lot of aliasing with significant MS, and this is her 3D showing a small annulus with a very calcified mitral annulus on 3D echo. This was her CT analysis that showed almost 360 arc of very dense calcium. And from the measurement, if you want to do TMVR and MAC, it's very important to calculate your neo-LVOT. And we had a neo-LVOT here adequate of 277. So given her age, her multiple comorbidity and frailty, we decided to plan for a transeptal TMVR and MAC, and her size was for an Edwards Sapien 26. So it's very important in the cath lab to get also from the CT and the fluoroscopy a good angle. Usually it's going to be an RAO caudal or an RAO cranial where you can see a line of dense calcium. Usually the way you do a transeptal puncture that is usually inferior posterior, contrary to the mitral clip where you go superior posterior. You want to try to get as close as possible to the valve. After you cross to the left atrium, it's very important to use an agilis with a pigtail in order not to get entangled into the chordae. After this, you have to dilate your septum. If you're using a 23 or a 26 valve, you can use a 12 millimeter balloon. If you're using a 29 millimeter valve, you use a 14 millimeter balloon. And here we took a Sapien 26. It was easily crossed. I was spacing from the LV wire, and this is the deployment. Usually I do a very slow deployment. This way you can have time to adjust between your first and a second operator, and you want to try to be as coaxial as possible to the mitral annulus. So this was the result directly after. You can see there is trivial leak, and on 3D echo you can see a very well seated, very well circularized valve with no PVL. However, directly the patient went into hemodynamic collapse. The pressure was 40-50, and there was a very big suspicion of LVOT obstruction. If you look at the hemodynamics, this is the LV pressure, and this is the aortic pressure. You have a peak-to-peak gradient of at least 100, and if you look at the aortic tracing, it has a typical Hocum tracing of spike and dome. And if you look at the 2D TEE, you see a lot of turbulence at the LVOT. I think part of the problem of why she had LVOT obstruction, it was simulated to be deployed at 80-20, and here I think we ended up with a 90-10 deployment, so we had more mitral valve into the LV and ended up with LVOT obstruction. And the way we dealt with it, we did an emergent septal ablation. We engaged with the EBU guide. We went with a 1.5 by 8 over the wire balloon. If you look at the right side hand, we injected agitated contrast, and you can see the basal septum lighting up beautifully on 2D TEE, and we ended up injecting 1.5 cc of alcohol. And directly, like magic, you can see the LVOT obstruction subsided. If you look at the aortic tracing, the spike and dome tracing disappeared, and you have a biphasic wave, and the gradient on TEE from transgastric and from the gradient went down to 14-15. Patient went home 3 days later. She did very well, but she comes back almost a year later with same symptoms. And when we repeated her echo or TE, now she had severe mitral regurgitation, suggesting of bioprosthetic failure. If you look, the mean gradient was now 10, and she had severe MR. We did a CT angio to make sure there was not early valve thrombosis, and on the scan, actually, there was some thickening of the basal leaflets, but there was no there was no leaflet thrombosis. However, I treated her with Lovenox, low molecular weight heparin and warfarin for 6 weeks, repeated the echo and TEE, and the MR and the gradients were not subsided. So we opted for a redo transeptal valve-in-valve with a 26 sapien. We recalculated the neo LVOT this time. Now we have a new valve, so we do the skirt neo LVOT, and the LVOT was 217. So hopefully this time there was not also going to be LVOT obstruction. We did the same maneuver, transeptal, dilating the septum, pacing from the LV wire, very slow deployment. We wanted to make sure that we don't dive too deep. Here I decided to do a kissing inflation balloon with an LVOT balloon in order to prevent LVOT obstruction. There was one report from Van Meegen about this technique that I've used a couple of times. I'm not sure how effective it is, but when you inflate the balloon in LVOT, you can direct the cells away from the LVOT. So here you inflate your sapien S3. At the end of the deployment, you inflate your LVOT balloon and you deflate at the same time as if you're doing a bifurcation lesion. We had a very good result. We had no gradient, no MR. On 3D echo, you can see the two valves with nice opening and closing of the mitral valve. And this is how they look on fluoroscopy. At the end of the case, actually, she had hypoxia, and there was a saturation of 86. I think the patient had now right-sided heart failure, and there was a right-to-left shunt. So we occluded the septum with a 16 millimeter ASD closure device without any issues. We actually saw her 3 weeks ago, and she's doing fantastic. Now she's been a year and a half since the last procedure. She had significant drop in her PA pressure. Her mitral valve gradient is less than 5, and she's doing very well. We repeated another scan, and her valve looks very well circular, very well seated with no thrombosis. And this is her latest scan showing. You can see actually the effect of the septal ablation here. You can see the shaving from the emergent septal ablation I did the first time. And you can see on the right-hand side the two valves side by side. So one of the considerations for valve of MAC is very important, is anchoring. Anchoring is your #1 issue. Do we have enough dense calcium? Is it circumferential? You need at least 270 arc of calcium. A lot of time you don't have anterior calcium, but you have posterior calcium, but you need to have at least some medial and lateral trigone calcium for anchoring. Very important to consider the risk of LVOT obstruction. The way to mitigate this is you either do lampoon. There's two techniques, antegrade and retrograde lampoon. Now everybody is doing almost antegrade lampoon. It's easier. And alcohol septal ablation prior to TMVR and MAC should be considered if your neo LVOT is less than 200 or your skirt neo LVOT is less than 180. Alcohol septal ablation post TMVR and MAC can be used to stun the septum. I've done it multiple times and successfully, but it's better to do it in a controlled setting beforehand if you have a suspicion of LVOT obstruction. I'm going to present another case, hopefully quick one. This was a 60-year-old female with history of aortic mitral and tricuspid regurgitation due to rheumatic heart disease. She had a mechanical aortic valve replacement, and she had a mitral valve repair and tricuspid valve repair with a 28 Carpentier-Edward physio ring, and then tricuspid, it was a 32 incomplete CE classic ring. Also, this is a patient who came to me very late in the game. She had recurrent flash pulmonary edema, recurrent ascites, and progressive worsening mitral and tricuspid regurgitation. So it's very important to know your characteristic of the rings you're dealing with, because there's a difference between a circling ring, a rigid ring, a soft ring, and an incomplete ring. Usually just a quick line. A suitable ring is a ring that is complete, circular, symmetrical, size less than 34, has good opacity, it's flexible or semi-rigid, which will lead to a secure anchoring ability. The unsuitable ring are the ones that are incomplete, non-circular, unsymmetrical, big size, invisible, and rigid. Rigid is a no-no for a mitral valve and ring. This lady had also chest radiation due to breast CA, so she was deemed also triple valve, chest radiation, frail. She was around 50 kilos, decided against redo surgery, and we were planning for a mitral valve and ring and a tricuspid valve and ring simultaneous during the same case. This is the mitral TEE. You can see severe central mitral regurgitation. And on the 3D TE on the right side, you can see the complete ring of the mitral valve. This is the mitral, and this is the tricuspid. You can see also severe, torrential, central tricuspid regurgitation. And you can, if you can appreciate on the septal side of the tricuspid, you can see no ring on the 3D TE. And the way we did it also, it's very important, same technique at the TMVR and MAC. It's very important to deploy very slowly in mitral and ring, and you have to use the push-push technique because you want to try to be as coaxial as possible with the ring, because if you are not coaxial with the ring, you might have the skirt on one side covering, on another side not covering, and you're going to end up with PV leaks. They are more tricky than valve and valve, so you want to try to deploy as slowly as possible. Actually, I did this case with Dr. Ghazal here sitting in the audience. So while he was deploying, I was actually pushing on the wire and pushing on the device to try to get as coaxial as possible. We ended up also doing the tricuspid. I usually put the wire in the PA, but when I put the wire in the PA, I was not coaxial. So after I crossed, I dropped the wire into the RV. And if you look at our deployment, we are going as slow as possible, adjusting as we go, trying to be as coaxial as possible. See, the deployment took around 30 seconds, but then when we thought we were coaxial in the middle of the valve, we ended up going. For the tricuspid, because it was a 32 millimeter valve, I ended up putting a 29 plus 5 cc's in order to secure the valve in position. This was the result of the mitral. It was actually excellent with no PVL and good opening and closing of the mitral valve. For the tricuspid, I had a mild central regurgitation from overinflating the sapien, which happens when you add 5 cc's sometimes of volume. This is how the baseline rings looked on fluoroscopy, and this is how the rings look, the valve look after deployment. Patient did extremely well. We did this 2 months ago, and gradients were below 3 and 4. Her PA pressure dropped from 90 to 30, and her EF was actually improved now to 45 from 30, and she's doing extremely well. This was the CT that I repeated 2 weeks ago, and you can appreciate nicely the anatomy between the septal leaflet, the septum, and between the tricuspid, the mitral, and the aortic valve. And you always do this. I check for leaflet thrombosis. I put her on warfarin just to make sure we don't have any issues. It's very important in valve and ring to know which ring you're using, to double check the vendor's data, to do CTs, to use the app, do TE, get all the imaging possible in order to have a successful case. I'm going to stop here. I'm not going to talk about mitral valve and valve because it's more straightforward. Thank you.